And good evening, everyone, and welcome to the Oculus Clinical Webinar Series. My name is Dr. Bill Tullo, Chief Medical Officer at Oculus, and I am extremely excited tonight to have a good friend of mine, Nick Despotidis, talk to us about myopia management made clear, strategies, insights, and clinical pearls. For any of you who don't know Dr. Despotidis, Nick has one of the largest practices in the country that specializes in myopia management. He's the lead author of 2 books, My Children Are Nearsighted Too, and A Parent's Guide to Raising Children with Healthy Vision. His workshop, Supercharge Your Practice, is the most sought-after practice management workshop or course offered by Vision by Design Symposium. And his TED Talk, A Childhood Disease Worth Preventing, educates parents on the growing number of children affected by myopia and the possible treatments available to them. With no further ado, I want to introduce my mentor in myopia management, Dr. Nick Despotidis. Take it away.
Thank you, Bill. Thank you very much for that kind introduction and for calling me your mentor. Nothing could be further from the truth. So tonight, my goal is to really differentiate what makes a very successful practice, not only myopia management practice, but a successful practice. Like Bill mentioned, I've been doing myopia management. I've been in practice over 30 years. And I integrated myopia control, myopia management about 20 years ago. So when I used to lecture about 10 years ago, 2015, when people asked me, why should I integrate myopia management into practice? Basically, I would state these 4 facts, at least in my case, is to improve profitability of my practice. That was one reason, strong reason I integrated into practice. We really wanted to reduce our dependency on vision plans. So we opened up cold over 30 years ago, 1988 or so, and we really realized as the number of plans we accepted grew, our profitability decreased and we were working harder and harder. So that was also a major goal. We also found when I was successful fitting children with orthokeratology, I obtained tremendous loyalty. It didn't matter if I was part of their vision plan, if I was in the book at the time. So those were 3 key reasons. And number 4 is there was a large barrier to entry. I needed a topographer. I needed equipment. I really needed to understand orthokeratology. And that really differentiated me from my peers, from my colleagues. But now fast forward to today, the landscape has changed. Yes, more and more practitioners are bringing in myopia management. And again, they're doing so in one sense is not only because of the myopia epidemic, but also to reduce their dependency on insurance plans and maybe create patient loyalty. But in my opinion, there's no longer a large barrier to entry. And that makes the myopia management landscape very interesting, very challenging, and very rewarding at this point. The reason the barrier to entry has decreased, in my opinion, the paradigm has changed. There's so many other modalities, really good modalities that practitioners can offer and should offer to their patients. There's soft multifocals like MiSight. Of course, there's orthokeratology, low dose atropine. Several of the ophthalmologists and optometrists in New Jersey and the East Coast are prescribing low dose atropine very freely. And of course, there's some novel spectacles. And we'll talk about a recent announcement, spectacles that are specifically made to slow down myopia progression. So that's a differentiation. When I started doing this 20 years ago, there was a large barrier to entry, but now because there's multitude of modalities that we could offer our patients, there's also a larger number of colleagues who are offering it, but not everyone's the same. And just the breaking news, Bill, I don't know if you heard, but today, September 25th, the FDA announced that the first pair of glasses, the Stellus made by Essilor, got approved today. And this is going to just blow the doors off of what we refer to as myopia management. An eyeglass spectacle, a lens that's specifically made to slow down the progression of myopia. And the reason I say it's going to blow the doors off, Most of us know how to fit a soft lens or prescribe low dose atropine, but I would say the majority of eye professionals, 99% or more, feel very comfortable with prescribing eyeglasses. So you could see why I chose for tonight's talk is how are you, the attendee, going to differentiate your practice from everybody else? Because now soft lens fitters can offer multifocal soft lenses. Practitioners who practice medical optometry, whether ophthalmology or optometry, could prescribe low dose atropine. And of course, we now prescribe glasses, hopefully in the near future. So how do you go from dabbling to durability? I'm not a dabbler. If you're going to get one thing out of this lecture is when you dabble, I think you lose. You become mediocre. You get frustrated. You work way too hard and you don't work smart. My success in practice and I think in life is I think long term, and that goes for myopia management. The dabbling dilemma, as I call it, is many practitioners have embraced or will embrace myopia management because we have an epidemic. We have a moral, ethical obligation to derail this epidemic. But number two is many of our colleagues view this, as I did 15, 20 years ago, as a potential profit center. We all know that there's a governor, there's a stopgap that how much we can charge when patients bring us their insurance. We get reimbursed whatever they pay us, the insurance companies. So many of us are going outside this realm to increase the profitability within our practice. However, I've learned, and you will learn or have learned, myopia management, if not done correctly, eats up your chair time. And there are parental expectations that get tough. And I am telling you now, because I've done this for a long time, is when the circumstances get tough, people will just pivot. They'll go to dry eye. They'll go to maybe eyeglasses. They'll go to NeuroLens or some other subspecialty when the water gets hot. And that's our opportunity. I am telling you now, no matter where you focus, the water's going to heat up. And at that point, most of our colleagues are going to decide to pivot. My success stems from staying the course. It's not because I decided to focus on myopia management and then everything went smooth and linear over the past 20 years. Nothing could be further from the truth. But what has happened is by me keeping my eyes exactly on the target, kids who are myopic, and I'm helping them specifically in my case with orthokeratology. So true differentiation, practice differentiation, is staying the course. And those are, I've picked three main factors that I kind of drill down when I look on why am I so happy? Why am I continually trying to evolve my practice to cater to children who are myopic, to treat them properly? One, I have consistent focus and commitment. I don't change course. Yes, I could be successful in any subspecialty I choose, but my focus stays very narrow. Children who are myopic. I don't do ortho K or myopia control on adults. I don't do anyone except children and who stay with me into young adults with ortho K. Number two, I've always believed in investing in technology. And I own a Myopia Master, and I'm going to talk about that, made by Oculus. And I own and paid for an OCULUS Pentacam. That's why Oculus has invited me tonight. But I'm telling you, I got the same deal that you guys got. I bought this instrumentation because I felt and still do that it was the best available to me and my patients. And number three, I continually educate parents at each and every follow-up. And I'm going to rehearse this and review it each and every time. This quote just came through in my inbox, and I thought it was appropriate, by James Clear, the author of Atomic Habits. It's hard to build momentum if you keep dividing your attention. And all of us have developed this ADHD because we all kind of go online and we see our colleagues may be successful now in, let's say, myopia controlling spectacles. So we start doing this. And then maybe another colleague has been doing very well with IPL. So we jump ship or change direction and we start doing dry eye. Or maybe some of us have gotten very good at coding and medical billing. So we feel, oh, we should be doing that. And I find when you dabble in all these different subspecialties, what ends up happening is you're mediocre at most of them. That's just my personal opinion. So tonight, I'm going to cater this talk on different levels of care. I have one advantage that most practitioners do not have. I was trained in vision therapy over 35 years ago. I did a residency in vision therapy. My practice still practices vision therapy. It's actually a very big center within my office. But I learned back then that there's different qualities of vision therapy, but they're all called vision therapy. And I'm not saying one is better than the other, but the term myopia management also encompasses that. In other words, someone may say, yes, I offer myopia management, and they just do low dose atropine and single vision spectacles. Nothing wrong with that. Another person may call myopia management within their practice orthokeratology. Another practitioner may just do MiSight or some type of soft multifocal. This all comes under the umbrella as myopia management. And consumers, the parent, may be confused, but also practitioners. So tonight, I've divided the type of care into three groups, three levels, if you will. Standard of care. I'm not talking about poor quality. I wouldn't even consider any of us doing that. Standard care, what I consider for this talk, is just a really good fit, whether that's eyeglasses or in this specific case, orthokeratology. The patient has good vision, you have a consultation for them, and you have this non-specific schedule. In other words, when I first started myopia management or even vision therapy, I saw patients in between my schedule. So I'd have an exam, maybe I have a tonometry check, and then I may have a myopia management check. So I call that standard of care. It's very good quality care. Excellent care has everything that standard of care has, but you have a separate consultation. In other words, in my practice, both for vision therapy and for orthokeratology or myopia management, I set up a separate consultation where I spend over an hour with the family discussing what I feel is the best option after I examine the child. And that may be any of the modalities that we discussed. I'm also very big on lifestyle discussion. I talk about smartphone use. I talk about the importance of sleep. I talk about the importance of going outside. That is part of my practice. I give snacks. If you've ever heard me speak, I think my practice is really an orthodontic type practice that disguises itself as myopia management. Why? 99% of my patients are pediatric or young adults who have stayed with me for decades. I write reports that we're going to talk about extensively, which helps me differentiate my practice from the noise out there. The noise mean all these practitioners are offering myopia management. How is a parent going to understand that I am the best option for their child? And that I call excellent care. What I strive for is what's called first-class care. And I've defined this. I go a little bit before. I do these virtual meetings before the consultation. So I meet with the family 20 minutes before they come in virtually to get a history. So when the patient comes in, I know already what is the best option. What do I have in store for me? Do I have a kid who's 6 years old who's going to cry, or a 12-year-old kid that's going to cry? Do I have a parent that asks me 101 questions about the efficacy of the treatment, whether it's low dose atropine, spectacles, soft MiSight lenses, etc. I give rewards every step of the way. So not only during the consultation, at the follow-ups, at the insertion removal, I have a scribe in the room. So you get the picture. There's different levels of care. And I'm not here to tell anyone what level of care they provide. I think it's innate within us. I have just wonderful optometric partners in my practice, and we all provide different levels of care. It doesn't mean that one is different than the other. We just accept ourselves for the practitioner that we are. So when I talk, I'm going to help differentiate. My purpose is to help differentiate me from the other practitioners out there offering myopia management. I think it's important that everybody gets this right now. The topic here is really how not to dabble in this subspecialty and what reward lies ahead. So standard of care, like we said, is an excellent fit, good vision, and a non-specific schedule. Excellent care is you're going the step, you're doing axial length. I'm going to talk a little bit about that with spectacles. Are you doing myopia management? If you prescribe spectacles, if you prescribe MiSight, but don't do axial length. And I'm not here to preach one way or another. I'm just here to give you my opinion. You need a dedicated follow-up schedule. I think no matter what you do. For me personally, I do think I'm obligated to talk about lifestyle. Again, I'm not obligated to give snacks, but I want children to look forward to come to my practice. Do I have to write reports afterwards? Obviously not. 99% don't, but I do. And I'll show you that has yielded tremendous success in my practice. I have a dedicated staff that is in charge of myopia management, just like I do for vision therapy, just like I do for my dispensary. So I'm a multidisciplinary practice, but my focus within my practice is myopia management. And excellent care is, bottom line is, I love when patients say to me, "You've helped shape my child's life." To me, I get goosebumps, and I'm not throwing any snow at you. That's what I strive for, is not all these bullet points. When someone shakes my hand and authentically thanks me for making a difference in their child's life, that's what really makes my job so happy and kind of fills in all the poop that I have to go through, that we all have to run our practices. So why do I do myopia management? Here is a patient, very difficult patient. Before they signed up, they wanted to come in and observe my reception area. I remember this gentleman before he even came in for a consultation. And one Thanksgiving, he sends me a card out of the blue that says, "Dear Dr. D, we've often take for granted the things that deserve our gratitude. So I'm sending a note to express our gratitude for the kindness you've shown to our family, our family." So this is why I have embraced myopia management. I don't particularly enjoy fitting a rigid gas permeable contact lens on children. What I really enjoy is making a definite difference in their lives. So I wanted to show this video that was taken by my wife before I think even iPhones were invented. So we used to rent out theaters. This is in Hamilton Square. It's a 24-plex AMC. And these are children and their parents waiting to come in to a free preview that I've provided. These patients are orthokeratology patients. This video is probably over 15 years old. Whenever Harry Potter came out with the last few, I would rent the theater a day before the premiere, and I would give away tickets to all my myopia management patients. This is my wife videotaping the people waiting outside the door to get into the theater. And she's doing this with an old-fashioned video camera. And this was, again, over 10 years, probably 15 years ago. So what I'm lecturing about is just not theory. If anybody knows me, I practice what I preach. So I feel, having done this for 20 years or more, is success in myopia management is understanding the demographic interested in myopia control. I really understand, actually, the parent who's interested in orthokeratology to manage their children's myopia. And I've learned that parent is very different from the parent that selects MiSight for myopia control. And that demographic is going to be very different from the demographic from the parent that chooses eyeglass spectacles special novel eyeglass spectacles like Stellus that just got approved for myopia management. So what I've decided is to narrow my focus to myopia control, to further narrow it to pediatric myopia orthokeratology, and even further, I really select parents who appreciate their children not wearing glasses during the day and concomitantly slowing down the progression of the myopia. So who is that parent? My experience has yielded it's the helicopter parent. Both my children are myopic. Both my children developed myopia from a very early age, second grade, probably before then. Why? Because I'm a helicopter dad. I'm not proud of it. I think it's in me where I constantly rode my children excessively in an effort to get them to succeed. I was misguided, but I was the best of intention. But that's my demographic, a highly educated parent, a parent who feels guilty that their child has myopia. Well, why? Well, number one could be genetics. Most of my parents that bring their children in, they're high myopes. Or like myself, they may have felt they've induced some type of myopia by the academic load they've placed on their children. Most of my demographics are competitive parents. They're word of mouth. Where do you go? Where do you do? Who's the best tutor? Who's the best teacher? Who's the best, etc. They want to go to the best, and they talk amongst one another to find the best. And basically, parents who view myopia as a disease. So this is really critical because I think when a soft lens parent just says, I'll take regular single vision soft, they're not viewing myopia as a disease possibly. And despite our best intention on educating them on axial length and the side effects of growing myopia, they still choose to go with single vision. That's not my demographic. So the way I'm going to kind of teach this course is how did I develop raving fans, raving parents? Raving fans are people that are compelled, not asked to talk about my practice, are compelled to talk about my practice unsolicited amongst other parents. And that's how I've grown my practice. I know no other way. It wasn't social media. It wasn't advertising. It was word of mouth. So durability is rising above the noise. What is the noise? Is today we can go anywhere for myopia management, at least in New Jersey. Bill, I'm sure you've seen this. I go to Costco, there's myopia management. My wife tells me there's myopia management in Target. I know Bill offers it. I offer it. Everybody offers myopia management. Well, how does a parent decide? Is it going to be who's the least expensive? Is it the person that has the cleanest office? Or is it going to be the person who accepts their insurance? So how did I and continue to strive to rise above the norms, the noise rather, is I try to get parents so incredibly happy with my care that they refer qualified referrals to my practice. In other words, they know which kids are myopic. They say there's a lot of people offering OK Lens or Ortho-K or MySight. Many of these parents, like I said, are educated. They've done their homework. And what I want them to say is, don't waste your time. You go see Dr. D. So how do you do that? I answered this question. How are you going to make patients so happy with your care, they become raving fans? And I'm going to tell you now, the answer is nobody says Dr. D corrected my child's vision so well. They see 2020 OD, 2020 OS, and 2015 OU. That's not happening. They somehow feel compelled to recommend my office. So it's pretty simple, but it's very hard to do consistently. I create raving fans by number one, communicating. I'm going to try to get this across you. How do I communicate? I communicate in every visit, from the pre-consultation, like I told you, a virtual call, during the consultation, and every follow-up visit, I communicate. And number two is I place urgency on responding to each patient's questions. This demographic asks a lot of questions. And that's why I said that's going to differentiate the dabblers from the sustainers, the people that really are going to prosper. The dabblers are going to get questions, their chair course is going to get eaten up, and they're going to pivot to something else. I have sustained the test of time in both vision therapy and myopia management long before it was in vogue. Why? Because I stay the course. I spend time during the follow-up visits. I follow up often, and I have a dedicated staff person devoted to myopia management. If you start growing your myopia management practice, but you could fill in the blank. You could say dry eye practice, whatever type of practice, glaucoma, medical optometry. If you start squeezing your patients in whatever subspecialty you provide into your normal schedule, I'm going to tell you, you fail. So if you come into my practice, we have a medical morning on Mondays and Thursdays. That's our medical. What does that mean is that's when all our visual fields, all our OCTs, all our glaucoma checks, our MAC scans, all happen those mornings. We don't do visual fields in the evening. Why? Now we're totally focused. The staff, the office, we've trapped those patients in particular slots so we could give our undivided attention. We do myopia management Monday, Wednesday, Thursday, Friday, all in the afternoon, 3 doctors. So I do myopia management just about every day except Tuesday. That's 3 doctors doing it within our practice. But I have dedicated schedules. Now, I didn't always have. I started myopia management schedule just on a Monday afternoon after school. It was something like 3 p.m. to 6 p.m. I didn't have many patients, but I didn't squeeze in emergencies. I didn't squeeze, like I said, glaucoma checks or RX checks or any type of exams. I devoted that to myopia management. So the 3 steps to success, if you've ever heard me speak, in my opinion, is first the consultation. So when we do, for example, a glaucoma evaluation, we don't say to the patient, hey, your pressures are high, your screening visual field is awful, I'm going to start you on drops. We take the time to explain to the patient why they have to come back for a consultation. So the success we have in our glaucoma clinic is because from the onset, we take the time to educate the patient because they're relatively asymptomatic. Oftentimes, as you know, for glaucoma patients, they come in for glasses or something like that. And then we just all of a sudden start talking about pressure in the eye and going blind. So we set up a consultation. We do the same thing with vision therapy. We do the same thing with myopia management. Why? The system works. Number 2 is follow-up visits. If you don't educate your parents on any of these subspecialties every time you follow up, you're missing a golden opportunity, number 1, to help your patient, in my opinion, but also to get those qualified referrals. And the third, in my opinion, key to success is insertion removal. I'm not going to have time to discuss that because we're limited in time, but I'm going to take my time explaining how you can grow your myopia management practice just by focusing on any of these. So during the consultation, I spend an hour, and this is after the pre-consultation virtual meeting. I educate parents prior, like I said, by the virtual meeting, during what makes our care different. So, for example, we're going to talk about the Pentacam and Myopia Master, but I take the time. See, technology, we all have technology in our offices, and I bet you they're all good technologies. The question is, do you believe in that technology strong enough to take the time to explain to your patient how you're going to use it, how powerful? Just before we went on, Bill was talking about how AI is going to help us tremendously in OCTs and so many other areas in our practice, but that means nothing to the patient. What means something to the patient is we've taken the time to speak to them without rushing them and making time to answer their questions. And I give plenty of snacks because I know, being a dad, you're good to my patients, you're good to my kids, I'm going to be good to you. You've already sold me. If you brush my kids off, even if you're the top doctor that was recommended, something doesn't sit with me, and I'm certainly not going to refer friends and family to you. And afterwards, I try to differentiate my practice, but not only by a virtual call beforehand. And by the way, we do this with vision therapy also. We get a good history beforehand. We do that with myopia management. We do over an hour consultation in vision therapy and also with myopia management, and we write a report afterwards. And of course, we give snacks in all our clinics. So why did I choose the Myopia Master? Long before I knew anybody at Oculus, I did my homework like you did. And time again, Oculus came up as a leader. And I'm saying this maybe because I'm speaking for Oculus, but it's the damn truth. I did my homework as you should. And time again, I heard its reliability. But I also heard that from other venues or vendors. So what I did is I called my rep, and I know him by first name, Terry Flynn. He comes in, he wheels this machine in, and he says, here, let's try it. Here it is. Let's feel it. I've called other vendors, and I get just distributors. So I knew right away, especially for me, I need hand-holding. I needed someone to help me not only take the actual axial length, I wanted to understand it. And I couldn't absorb everything right away. I'm continually learning. I've owned that Myopia Master about 5 years, 4 years, right after the pandemic, and my Pentacam even longer. So I think one of the key differentiators in my office is how I use the Myopia Master. So I just don't use it to take my auto refraction, my Ks, my axial length. I try to educate the parent on what's going on. So I do that verbally, but I write a report. I write down what this examination is, what is a sphere, what is a cylinder, etc. And then I add the axial length. And I go into detail. Number one, I use an Oculus product. You'll see all the reports, whether it's to parents or to professionals, that they know I want them to know I use the Oculus product. Why? Long before I bought my Pentacam, the corneal specialists that used to refer to me for sclerophytics were using a Pentacam. When I refer a patient for laser surgery, I wanted to get a Pentacam because I wanted to make sure that the posterior cornea was viewed, not only the anterior. So I take the time not only to show the parent while they're in my possession, while they're in my consultation, I try to write a report. I always write a report. I don't try, but I try to explain within the report the data, because as parents, they can't absorb everything, whether they understand it or not. And I'm going to tell you, more understand it than don't. They'll ask me questions from the report that sometimes I'm not able to answer. So not only do I go through the data in the report, I explain what axial length is in the report, and I get that from the Myopia Master. And then I explain the options only if the parent says, hey, I want to know all my options. Otherwise, I just tell them what I represent. And long before I owned Oculus products and long before Oculus purchased Wave, I was fitting Wave contact lens because, in my opinion, they're the most customizable lens out there. And I may be biased, but they're also the best. And I purchase my lenses. I am not paid by Oculus for this opportunity right now. I am telling you the truth. And if you look at the arrow, the reason for it is I make a point of saying when it's most important that my lenses are custom designed. And the reason I do that is to help me grow above the noise. There are many practitioners, including Dr. Tullo, who practice in my area. I need a unique proposition, a uniqueness. So I really do believe in the product. And then I take the time to explain to the parent why I'm using the product. And not only that, how I'm using it in the exam room. So Bill, I want you to take some time because the Myopia Master has a lot of information on it. So I actually solicited the help of Dr. Tullo to help me explain when parents want to know the axial length and they don't sign up, because not every patient, about 20%, decide not to do myopia management with me. They may go elsewhere. They may decide not to decide and come back in a year. So, Bill, I've showed you this report. I've modified what comes in the Myopia Master. Can you explain to the audience that's not familiar with this graph what this graph is?
Sure, Nick. This is the BHVI graph of axial length, and it shows us on the x-axis the patient's age, on the y-axis their axial length, and you can have multiple measurements for each eye over time. But the way I utilize this graph is during the initial consultation, or even in the pre-consultation video call that you do. I use this measurement because in my practice, every kid gets this measurement, whether they're getting a routine eye exam or they're coming back for a consultation. So I have this data initially, and I use it two different ways. Number one, it shows me what percentile they're in with their current axial length. So it shows me their relative risk of progressing. In this example you have here, you can see this kid is around a 75 percentile. So he's well above the 50 percentile. And the parents understand this curve in particular because it looks just like what they get from the pediatrician for height, weight, circumference of head, all these things that they get for the kids during pediatric visits. So when I use it to talk to a parent, I know they're understanding the points I'm making. Before I had this, it was a very abstract conversation, and although they would nod their head, oftentimes they wouldn't understand what I was saying. And the beauty about this is during that initial consultation, when you're spending a lot of time with the parent, you want to make sure, and I always ask the parent, okay, tell me what you understand. Repeat back to me what I just told you. I want to make sure you really understand what I'm implying by this. And the second thing I use with this curve on the consultation too is the predictive nature of where we will be if we do nothing. And so this graph here shows us again, how myopic that child will be with a bell curve of uncertainty. But using the middle of that bell curve, I will say, look, if we do nothing, and years ago we did nothing, here's where your child will end up if we do nothing. And that's a very impactful statement to the parent because of the things that you mentioned. Usually they're sitting there wearing their -8 glasses. We're having this conversation, and the guilt is clearly there. And you can see with this child, when you blew it up here, they're about a -6 they're going to be if we don't intervene at all. So I say, look, in this child, maybe they're a -2 right now. We may not be able to stop this totally, but we can certainly get a much less than that -6 that if we do nothing at all. So the good news is we found this child here. They're 12 years old. And we've got it fairly early on. So if we intervene now, there's a good chance we can mitigate a lot of that myopia that if we just go ahead and ordinary contacts and ordinary glasses will not slow this down. And these graphs are very accurate. So they're going to get more nearsighted if we do nothing. So I use this to set the table of my myopia management. Now, this next graph to me is probably the most important tool I have from the Myopia Master, and that's the annualized axial growth rate, because this is how I explain to parents why the therapy we are doing is either working or not working. It uses age-adjusted norms to tell us that the annualized change in this eye is either green normal, yellow suspicious, or red abnormal. So let's say I have a 6-year-old on atropine and I have them on maximum dose and they're in the red. Well, clearly atropine is not enough for that child and we have to pivot. So the parents understand very clearly green is good, stay the course. Yellow is suspicious and we want to watch that carefully. And red means we need to pivot and do something else, whether that's adding atropine to an ortho-K patient or adding ortho-K to an atropine patient or whatever it is. It means that whatever we're doing is not good enough. And the beauty about this is it's just not a static number. It's a normative age number. As you'll see, the red is totally different for an 8-year-old than it is for a 12 or 15-year-old. And so this tells me, again, with age-adjusted norms, are my treatments working? And if they're not, what do I need to do? Because with ortho-K, as you know, you can't even try to use spectacle RX because they're plano. You can't follow that unless you wash them out every year, which is not a practical thing to do to any ortho-K patient. So particularly with ortho-K patients where axial length is really the number you have to monitor, again, this tells us exactly whether our treatments are working or not. So I use this on every single follow-up. Every parent wants to know on every follow-up, are we in the green? Are we in the green? Are we doing well? So to me, the software is as valuable as the hardware is. The software is really the key to my practice, and what makes my hour consultations would be 2 hours without this. And my parents would go home, they would tell the other spouse, and then I get a phone call the next day because the other spouse doesn't understand. With these reports and with these graphs that are very simple to understand, the parent that's during the consult goes home, talks to the other parent, and I almost never get the next day phone call anymore. And it's because of these two graphs that really reduced the amount of chair time and phone calls that I have to return the following day after consult day. So that's the way I use it in my practice, and it's been really remarkably effective in parents understanding and also the conversion rates of parents going to therapy.
Yeah.
I mean, before I used this, my conversion rates were less than half than what they are now.
This helped me with the conversion rate. And there's two things I want to notice is notice the date. It's all, it was just a week ago. It was September 11th. The other thing I want people to notice is there's two data points. This patient came in last year and did not sign up. They decided not to do anything, not any of the treatments, and talk to their friends. And then they come back about a year later, and I can show them with just 2 visits, the steepness of the curve. Like Bill says, is I'm showing them their son is in the red zone. So there's urgency. And I basically say, as part of the treatment plan, let's just start using lubricating drops to get this child used to something next to him. But the bottom line is we have to do something. And this year they signed up. So why the Myopia Master? I do think that there is recognition about Oculus, its accuracy. I can go on and on and on, but the reason I chose it is when I deal with other professionals. This is another professional. I think I'm referring this patient for a retinal exam. Many of my patients, I don't accept any vision plans. I personally don't accept any medical plans. So some of my patients, at least 25%, go to their primary optometrist or ophthalmologist for their annual exam. But I want, like Bill just said, they're going back near plano. They could be minus 75, minus 50, but the doctor doesn't know beneath them there's a high myope with an axial length that's quite long. So when I do write a report sending my patient back, I make sure that I put in this is the A scan, and this is the machine that I've taken on. This is the technology. So I just want to move up to follow-up. So that was consults, right? Like Bill said, I still get a lot of questions even after the report, but that's okay, because for me, I have the time, and that's marketing for me. Is if I can get a parent who understands why my system may be different than all the noise out there, they're going to become a raving fan. So with follow-up visits, I make sure I make the time. So this is something I don't think you'll find as funny as me, but I wanted to put it there. This was just the other day. I don't know what today's date is, but it's July 23rd. So obviously very, very recent if it wasn't yesterday. At 4:37, I write emails after every Ortho-K visit, myopia management. We have 2 ways of doing that, because remember, sometimes on a Wednesday night, we have 3 ODs seeing myopia management patients every 20 minutes. So that's 9 patients an hour after school, 3 to 6. So we need to make sure that the parent understands, or if they have any questions, to let us know. So we have a standard email, and I have a personalized email that I send out using AI after every dad who brings in their kid. I want their mom to get an update, because as a dad, the worst thing that could happen to me is I go to the dentist with my son, I come back, and my wife asks me, does he have to wear his retainer? How long does he have to wear it? Did he have cavities? And I look at my wife, I said, I don't know. He said, everything is fine. So I know that it helps the dad and the mom. So here I thought it was really slick, right? It's a really nice email. It says, Miss Jones, I'm pleased to report that Jesse's eyesight has remained stable, and his good left eye, because he only wears an Ortho-K lens in one eye, is stable. He's taking excellent care of his lens, and no changes are necessary at this time. And this is where I really thought I was going to get a raving fan, right? I also recommended that he step outside for 5 to 15 minutes after an hour of studying to help offset the screen time. Listen to this, guys. This is the God's honest truth, especially with SAT and AP preparation. please don't hesitate to let me know if you have any concerns. I go to myself, good job, Nick, slam dunk. This was perfect. The mom says, thank you for your email. May I have Jesse's axial numbers? So let's see. So it's 4:37. And at 5:09, less than 20 minutes later, she's like, yeah, Dr. D, thank you. I've heard this before. What are the numbers? And this is a catch 22. Bill, how do you get this, number one, and how do you handle it?
Absolutely. Not only do I get what are the numbers, then I'll get what do the numbers mean also.
Okay.
So is this all right? So is after the follow-up email to this after you give them the numbers is okay, is this good or bad numbers? Because they don't know what the numbers, what change is consistent with an issue or is with stability. So, I get exactly this, whether it's an email or a phone call or a sticky note sitting on my desk when I get back to it. Yeah, this is exactly what
Okay.
happens. And
So
it's the helicopter parents.
yeah, and that's fine. So you have a choice. Remember the dabbler? The dabbler is going to go, I'm going to answer this, but holy moly, I don't want to deal with it. I'll go back to glasses. I'll deal with RX checks here and there. I'll see them in a year. Same thing. Oh, my friend's killing an IPL. I'm going to go back to expressing my Bohemian glands and taking care of all sorts of things, but I don't want to deal with this parent. But I do. Remember, I'm not a dabbler. So instead of just saying, like Bill just said, here are the axial length, because sometimes, you know what, guys, you know this, if you've done refractions and they change hour to hour, sometimes certainly day by day, visit by visit, and axial length is the same way. If you don't know, the axial length actually changes from morning to night depending on the thickness of the choroid. So how do I explain that to a parent? How do I explain that we're looking for multiple data points and your child is going to grow, including the axial length? So sometimes just giving them the data is not enough. It's often not enough. So instead, what I've learned, remember, this is how I've grown my practice. Instead of saying, here's the data, I'll summarize Jesse's record and have them forwarded to you. Once you receive them, if you have any questions, let me know. This is the difference between the dabbler and the real leader in the field. Because I'm telling them, bring it on. I know you'll have many questions. I actually know that you have many questions. So this is how I deal with it. I write a report. I use my EMR. I use a whole system that I have and you guys have to create this record. And I want them to know in this particular kid's case is I'm on top of it. Look, I put the SAT in there that he's taken August 23rd. I put down that data. I put down the axial length. He's myopic in the right eye, barely myopic in the left eye. And then I give them the numbers. And you could see in this data, his right lens is the myopic lens that has a much longer axial length. The right lens is 26.38, the left 24.50. I want them to know, look at where the right eye is, look at where the left eye is. So I make it clear, this is what's going on. This is normative data, like Bill said. This is based on growth, on data. I want them to know I have this data. I don't offer it exclusively at every visit, but when push comes to shove, how do you create a raving fan? Is you keep answering their questions until they're satisfied. That's at least how I do it. And of course, I want to show them that in this particular case, there is some growth, but it's relatively stable. And most times when I do this, either the parent understands it or not, but like Bill said, coincidentally or not, I get silence. It's like, thank you, Dr. D. Now, is this a lot of work? Hell yeah, it's a lot of work. I'm doing a great job just getting the lens to center, just making sure the patient gets snacks and the patient has a wonderful time. And I get to speak to them about school and SAT and AP courses and maybe their dog or tennis. And in addition, I have to kind of stabilize their myopia. This is how I've grown my practice to a multi-million-dollar practice that's, I would say, majority myopia management. And I also give them their topography, which in this case is the Pentacam, and we'll talk about that. So why the Pentacam? Why did I choose the Pentacam? I guys, like all of you, I had a topographer through the I guess 1990s and through the 2000s. And it was great. It was a workhorse, but it also was archaic. And when it came down to buying a Pentacam or a topographer, I suffered through it. I do what you do. I call my colleagues. What do you have? What do you have? And I read journals. But the bottom line is, this is not a topographer. The reason I made a decision, the Pentacam is a tomographer. And I'm going to have Bill go over some sophistication, because to be honest with you, when I really need to understand the data, the software within the Pentacam and this tomographer, is I have trouble, and I've owned it for 5 years. The difference between the Pentacam and the other topographers I was looking at, the Pentacam looks at the posterior surface of the cornea. And for me, that does so many contact lenses in orthokeratology, for me, that does so many pediatrics, I want to pick up a cone. And this email solidified. It was on the AAOMC Google group. This is the people that run Vision by Design. It's an OrthoK Google group. And here's someone that said, I know not all docs have a Pentacam, but it's really amazing how many mild cones it gets missed without it. And he hit me where it hurt, because I've been doing this a long time. And at least once a year, I get unhappily surprised by a child I was treating with either soft or rigid lenses that had a cone. And now in their late teens, 20s, I have to explain. We've all had to do this. Explain to a parent that their child has keratoconus and what that means, and how come we didn't pick it up sooner? And number two, how do we explain the contact lens that the child was wearing did not cause it? And that's why I chose the Pentacam. So here's a perfect example. There's multiple positives that I want to share with you. First of all, like some of you that have a contact lens practice, I depend on corneal specialists to refer scleral fits with me. Unlike OrthoK, it's word of mouth. It's on the soccer field. My partner Ivan does all our irregular corneas. And the way we've developed that practice is not word of mouth. There's not many keratoconics. I know other keratoconics. We don't do advertising. And if you go onto my website, it doesn't say anything about fitting specialty lenses. It's getting surgeons that see the irregular corneas get referred to us. And what do they use? More often than not, the Pentacam. So I want them to know I own a Pentacam. And this is something that will stay with me. This is a young lady. She's now 13. I've been treating her since she's 10 or so. And she wears soft toric multifocals. And if you notice, I don't know if you could tell from the letter OD, she's -5, -1.25 at 10. But her best corrected vision through the years, I could not get her to see 20/20. And then I start saying, why? Like all of us should. Is it her retina? Is it the cornea? Is it a microtrope? And if I could tell you, I worked her up, but the Pentacam, it wasn't conclusive. If you notice where the arrow is, there's a Balin Ambrosia Enhanced Ectasia display. In other words, that's a fancy name for the person that devised the software that helps detect a cone on the posterior surface. So it checks an ectasia. So it was inconclusive, but it red flagged it. So I reach out to Bill, and Bill was kind enough to go through all the tomographies that I've taken over the past 3 years. And I really thought AI did this. So Bill, this is even over my pay grade. I want you to explain to the attendees what this graph that comes from the Pentacam means.
So sure, this is called the Bellin ABCD progression display, and this display is very helpful once you have 2 or more examinations over time to tell if the eye is stable or changing. And with diseases that are ectasia, we look for change over time. And the hardest part is with orthokeratology, because we remodel the front surface of the cornea, the normative database no longer applies to the front. But thankfully, almost all keratoconus begins in the back of the cornea, and OrthoK does not alter the back of the cornea. So we can look very carefully at changes over time to see if they're progressing. And this software uses normative databases. It has 3 databases: a green database for eyes with no diagnosis, a red database for the eyes that have a keratoconus diagnosis, and then even a blue database for eyes that have been cross-linked to see if they're stable after cross-linking. But for your patients, since they don't have a diagnosis yet, they just have signs with reduced best corrected vision, we need to look at each and every topography from visit to visit to visit. And this graph allows you to put all these visits right next to each other. Instead of having a table full of 20 papers that you have to look at, this puts it all in one viewing. And it allows us to see the A on the top are all the visits that you measured the anterior cornea. And we can see from that first visit in yellow up top to the last visit in pink on purple on the bottom that there's been significant progression over that time period. Even more importantly, we see the back of the eye, which is the B factor, is the posterior cornea. We see from that yellow first visit to that pink last visit, it's exceeded the 95% confidence interval. So these are the things we look for to substantiate that this cornea is not stable, that it is changing over time. And even with the corneal thickness, which is the C measurement, we see how the cornea thinned over the visits over time. So we have three measures, A, B, and C in this particular patient that have all clinically significantly worsened over that time period from the yellow exam down to the pink exam. So in this patient, in this eye, it was easy to find when you look at the data together with the normative data comparison that this patient is progressing and they are getting worse. Even if their acuity didn't change over that time period, their eye is worsening. And if it was an ortho-K eye, it's even more challenging to figure it out without this data. So this data, and again, if you have a Pentacam before you start ortho-K, get a baseline measurement of the back of that cornea so you now have a comparison. No matter how long they're in the lens, you can follow them carefully to make sure, because sometimes we all fit ortho-K patients at really young ages, 5, 6, 7, 8 years old. There may be no starting of keratoconus yet, but then the 10, 11, 12, 13, the disease can start. And if you're looking just at the anterior cornea with placido, you will not see the changes until they're significantly well along the way. And I talk to so many of our colleagues and friends, Nick, that do this. And every time they do find a case where they wish they would have seen that back of the cornea a year, 2 years, 3 years ago, it's the worst feeling in the world. And even I've had that feeling too with my own patients before I had Pentacam years ago. It's a horrible feeling to say, wow, if I only would have had that, I would have seen that. And I could have got those kids cross-linked a lot sooner before their loss of best corrected vision went to the front of the cornea, which is much harder to undo at that point with cross-linking.
Right. And that's why, going back one slide, I referred it to a corneal specialist at Wills Eye Hospital. They chose to wait till Epi-On is available. The parents educated, but I could tell you, looking at the front surface of this young lady's eye, there's just no sign of keratoconus. You just have to take it from me, looking at thousands and thousands of topographies over the years. And so this specialist it's a double win, because the parent knows I've detected something that 99.9% of practitioners in the field, the noise, if you will, would not have picked up. Number two, the specialist I referred him to, I am telling you, although he didn't email me, says, okay, this guy is doing a good ethical job. When I have a patient, I'll refer it to Nick or Nick's office. So,
Practice builder, yeah.
Yep. So just to conclude, and hopefully we'll have some time for questions. I am telling you, in my experience working with Oculus and Wave through the years, I can honestly say they have the best instruments. I think they have the best custom lens design. And I have the ability, and I've worked with all designs. When I need to customize it, in my opinion, in my experience, dealing with Wave over 20 years, there's no better design. And I could tell you, it's the best customer service and support. I know Michelle has helped me, Dr. Tullo has helped me, Jake has helped me. I know Brittany, I know Shelby, I know Ashley, I know people by name. Why? Because number one, when I call them, they help me. And they don't make me feel silly. They don't make me feel dumb. I just had a very good friend and colleague say, Haley, what lens do you fit? Because this person who's helping me at tech support is basically saying, I don't know what I'm talking about. And we've all had that happen to us by a consultant. I could honestly say I've never been anything but respected by this company and well supported. And that's why I'm speaking today. So, Bill, just two more things.
Mhm.
I wanted to ask everyone to attend Vision by Design this year. It's next month in West Palm Beach, Florida. Dr. Tullo will be there. I will be there. The lectures are all about myopia management by people who do myopia management. This is where I got the bug over 20 years ago to do Ortho-K. I can't recommend it enough. Bill, what day are you going to be there?
I'm going to be there, I believe, Wednesday through Saturday.
And do you have a booth there?
We do. We have two booths. We have an Oculus booth and a Wave Eye Care booth.
Okay. And I give a workshop there also. And again, of course, I'm biased, but I go step by step in an all immersion course for a full day that talks about how to charge for myopia management, how to grow myopia management, how to take great care of your patients, and how to develop a staff that really supports you and that you enjoy going into your office every day. So I can't recommend that enough. So on that, Bill, I want to thank you very much.
Nick, thank you. And I just want to mention I've been to Supercharged 3 times now, and I learn something new every time I go. And I've never been to any course that has impacted my practice as much as this course. And that's the truth. And I'm going to give you a couple of examples I just wrote on a sticky note to remind myself. On my first Supercharged, one of the first things I learned from you is that I was doing my evaluations all wrong. Even though I was doing evaluations separately, which I thought was great, I had my old LASIK TLC mindset that I'd give away the consult for free, and then I would charge them for when they sign up for the service, whatever service we recommend. Well, it turns out that when I looked at it, I had less than 50% show rate on my free consultations. And then after speaking with you after my first supercharge, I ended up charging $375 for my consults, which I would apply to whatever program they signed up for. And now I have a 99% show rate, because if they're going to pay for it, they're going to show up. When I gave it away for free, they would show, maybe they wouldn't. It just, so that was probably the first thing I learned at the first supercharge that I was doing wrong. The other thing I learned too, you talked about the application and removal training. I used to always let the parents come back with the child and stand there and interrupt and make it. It would take twice as long. And then when I went to your office and watched you and your staff do it, and how you separate the child from the parent purposefully, I was like, that's brilliant. I mean, and now I never do it any other way, because almost never do the parents add to the process. They always subtract from it, or even make it a disaster. Actually, they make the kid so uptight. Yep. So that's another thing that I learned from you and from that. But I think I wanted to mention also about using this software on both the Myopia Master and the Pentacam. Again, in my exam lanes, this software is always there, so I can show the parents what this is and how this is different from every other practice that is around me, including my Wave software. I'll even do a make-believe lens design. I won't actually order the lens, but I'll do one just to show the parent how different this lens is from all the other off-the-shelf lenses that they could get anywhere else around me. And again, to differentiate the practice. So again, I'm going to be at my 4th supercharge this year. I'm looking forward to it. And I know I'm going to learn another thing new that I'll bring back and drive my staff crazy with, but it works. And again, I highly recommend, if you're in the beginning or even the middle of developing a myopia management practice, there is no better course that you can go to. There's no better time you can spend than taking Nick's Supercharged course. It is fantastic.
I appreciate that very much. Thank you, Bill.
Nick, I want to see if we have any more questions. Let me just take a peek here. All right. I think we've answered this question too. Nick, here's a question. If you inherit an Ortho-K patient from another practice, so you have no baseline topography or tomography, and you may be suspicious, what would your next step be? Would you wash them out at that point? Obviously you can still take a Pentacam and look at the back of the cornea, but how would you handle a situation like that?
Yeah, I wash everybody out. Tonight we have a consult. I learned from the pre-consult they wear what Dr. Tullo says off the shelf, and we wash them out. There's 2 problems with current wearers. A person who is fit, who wears Ortho-K, they're coming to us for a reason. relocation, but also they may be not happy with their current doctor. And there's a reason for that. So when we take on cases, we start fresh. We wash them out. We give them soft lenses. It's part of our program. We teach them how to do a soft lens INR, and then we go back to baseline. And I say the reason we do that is so I get new accurate data. And from that data, I'll design a lens that's custom made for the cornea, and we'll monitor them forward. Every time, even if it's from a colleague I trust, when I take on a patient, it may be good for a year, but then something happens, and then they're my problem. They're no longer the problem of fit. So I just start from fresh. I don't know how you handle it. Even
I
when
do
they wear
exactly the same thing, because you never know from the notes you get from other doctors exactly what's in that eye and what's been done. The notes are usually pretty poor, and so I really can't depend upon knowing what happened.
right.
Starting from scratch, as frustrating it is, maybe I'll fit them in soft lenses in the interim to get their corneas to go back, just so they don't have to wear glasses. But I will wash them out completely, and sometimes it can take a long time. I've had patients take 6 and 8 weeks sometimes to wash out instead of the usual 1 or 2.
Yeah.
Because designing the lens from a half washed-out eye is almost worse than trying to fix one that you didn't create to begin with.
I recommend to that person, wash them out, start straight, or let them go somewhere else. It's just I've never been able to really take on a case.
And we didn't talk about tiered pricing, but they go up a tier automatically when that, because I know that I can't predict how difficult this is going to be. Even if it's only a -2, it could be a really hard case because of what's been done to the eye before we touched it. So I have another question that's more of an Oculus question. This question is, with the Myopia Master and the summary report, can we put those graphs in that we saw in Nick in your printouts? And the question is, the answer is, with the current software, you can get the BHVI graph in there, but you can't get the important annualized growth rate curve in yet. A future software upgrade will allow you to do that. So what Nick and I do, we just cut and paste. We'll do a snippet. We'll snip the graph we want, and we'll just paste it into the Word document, which takes a little bit longer. But in future iterations of the Myopia Master software, we'll be able to incorporate all the graphs into any report that you want. It's a coming soon feature. All right, let me see. Okay, I think we've answered everyone else's question incidentally, which is good. So, Nick, I want to thank you so much for you sharing the wealth of knowledge with all of us tonight. Again, even tonight, I've learned new things that I'm going to take to my office tomorrow and charge my staff with making some changes in our practice. So, thank you so much for sharing. I look forward to seeing you at VBD in a couple of weeks.
Thank you.
It's going to be a great meeting. It always is. And thank everyone for coming tonight. If you have any questions, this recording will be available to be rewatched. You'll get a link within a week of the recording. So thank everyone for coming, and have a great evening. Thank you, Nick. Again, really appreciate it.
Thank you, Bill. Thank you, everyone. Have a great night.